the question is, so it was discovered with him with this motion, flexion, motion extension X-ray. Can you explain what that is and how that's different from regular imaging, and when someone should be advocating or reaching out to get an imaging like that?
Motion X-ray is more than just flexion and extension. It's dynamic, it's real-time video. And flexion extension, unfortunately, is the only component that gets assessed in mainstream medicine. So they will do a flexion and extension regular X-ray. And it's not really, it's a flexion position, still snapshot. They'll do a snapshot in neutral, and then they'll do an extension snapshot at the endpoint. However, they miss what happens from endpoint 1 to endpoint 2. And having conducted thousands of motion X-rays myself, I can tell you that the point of most incriminating excess motion rarely happens at the endpoint, because our neuromuscular system has an amazing capacity to recalibrate position once we've reached our end goal. So it's during the actual motion from A to B that you often see the excess motion that would be pathologic. And then once you get to the endpoint, it recalibrates to make it look like it's not as bad. And so when you do a static regular X-ray in the flexion position, so you haven't watched them move into that position, you've just positioned them there, said don't move, don't breathe, take a snapshot, and you do the same thing in extension, you can possibly be missing much more noticeable pathology between those endpoints. And then moreover, motion X-ray, we also focus on doing a rotational component, because obviously our necks and our heads can rotate, plus they can tilt side to side. So there are 3 dimensions of assessment that should be done, and we do with motion X-ray, and we have been the entire time we've been doing it, whereas medicine tends to focus on the flexion and extension component. And so if they don't notice anything in the flexion and extension, because they're mainly focusing on the ADI, which is basically the front part of C1 separating from the dens of C2, assuming that only the transverse ligament is the possible perpetrator. But we've got several other important crucial ligaments that connect the skull to C1 and C1 to C2 that can't be assessed in flexion and extension. And so the 3-dimensional approach tends to provide the most relevant information that is clinically helpful, both in therapy and also prognosis and expectation. And I would probably say that the open mouth side to side bend, looking at C1, C2, is by far the most relevant as far as diagnosing upper cervical instability goes.
Crazy. I love it. So I know people travel to come work with you from all over. You like we talked about, you practice in Canada and United States. Yeah. So if someone has this, then what? Like, what does treatment look like? I'm sure you do more than just diagnose.
Yeah.
So then what does treatment look like after that?
Sure. And I've actually posted a lot of this to, freely help any therapists or clinicians out there who are possibly dealing with this, and even patients who may not be able to get in for a treatment 5 times a week, because ultimately this type of therapy, when you have these problems, is actually 7 days a week is justified. And so to be able to learn how to do this to yourself. And so I've got, these videos in the short section of my YouTube channel. There are shorts on how to treat this yourself. And then one of them shows me squeezing my SCM. That's the tile for that video. And then there's about a 10-minute video that would be intended for clinicians, giving an overview of the structures involved in the upper cervical spine that would be most commonly needing treatment, because it generally is a rotational instability at C1, C2, because the number one job of C1 and C2 is to rotate. And so when you damage the ligaments there, you already have the most mobile component of our spine becoming even more mobile. And so it's a rotational instability. So you want to be addressing the rotational muscles that would support rotation. Or that would be on.
What we'll do, Sasha, I'm just going to interrupt really quick, because for those listening, is we will drop the links to both those videos in the show notes, both that short one and the longer one. So I'll get you to send those to me after, so that way we can just drive people right there, so they don't have to go searching for it. We'll make it easy for them.
Absolutely, yeah, absolutely. But the premise is that because you have permanent ligament damage, and so if I could define permanent ligament damage, that means that it's actually not going to heal. So what would be considered healing that happens in a damaged ligament is generally, so if this is the normal integrity of a ligament and you've got it partially torn, so now it's lengthened a certain factor, it does not recoil back to the resting length and then heal or scar. So what happens when you have that stretch or that deformation of the ligament, it's going to scar up and heal in this length position. And so now, no matter how you slice it, those bones will move that excess amount from that moment on. And because our muscles have sensors built into them, and there's also another YouTube video there where I explain this to a massage school, the sort of neuromuscular component and how that eventually involves the central nervous system, which then leads to an elevated tone of those muscles, which causes these patients to repeatedly come back to us with the exact same muscles being overly toned or tight.
Mm-hmm.
But the notion is that these muscles respond to that instability in an involuntary way. So they sense themselves stretching, they contract by default. That's their natural response. And as they repeatedly do that, then nerve signals start to trickle up into the central nervous system. Central nervous system gets involved and actually sends a tone change down to that muscle so that it doesn't have to undergo that stretch as much because it's already pre-shortened. And so because of that phenomenon, then people's muscles get tighter and tighter and tighter to compensate for that instability. And at some point in time, that tightness relates to what then chiropractors term as a malposition or as a subluxation. And so then you can address the subluxation as an isolated entity, or you can assume based off the patient's symptoms that they might have actual instability. And so the tightness is not truly coming from the joints, it's coming from these muscles that have become more rigid as a means of protecting themselves. And so the technique that I implement is basically NIMO, receptor tonus technique, which basically translates into acupressure. And so that's basically finding the trigger point in these muscles and pressing and holding. And I've sort of taken that concept of Dr. Nimmo and I've made it my own, if you will, because their premise is holding a muscular tissue from 7 to 10 seconds and a ligamentous tissue from 3 to 5 seconds, where I tend to hold the trigger points for a minimum of 20 seconds and sometimes even well over a minute. And by doing that, the depletion of the lactic acid and the forcing of the cross bridges to release actually puts that muscle back into a responsive and functional state, so that it can again undergo the stretch, contract, eventually involve the central nervous system and eventually change the tone, thereby needing treatment again. And that's why it's so relevant for patients to be able to be empowered to self-treat should they be willing to try and should it be successful for them, because it is an actual thing that they would need to do daily and sometimes multiple times a day to hit that reset button so that they can function within a somewhat more acceptable norm. So they're not always depending on a treater to do it passively.